So let's take a look at the device. What you'll see on the DisImpactor is that it is a injection molded polymer that has a long shaft that's quite flexible. If we start at the far end, you'll see that it has a bullet tip. The bullet tip is shaped to accomplish a few factors. The first is to allow easy entry past the anus into the fecal load. The bullet tip is also shaped to easily enter the fecal load itself. Beyond that, we have our flexible silicone-like fins. And basically, these are designed in an umbrella mechanism so that they cant downward upon entry, but as we pull back, they provide a catch. And that's going to be the traction component that the DisImpactor has on the fecal load. In between the fins, you'll see that there's a number of ports. We call that the point of impact ports because it's through those ports that you'll be able to instill enema fluid deeply into the impaction, and the ports are situated on both sides of the device. Moving a bit more proximally, you'll see that there's a reverse bullet point, and that's so that as the device is withdrawn, it helps to dilate the anus and allow the device to be easily removed. Moving to the proximal end, you'll see a large church key handle, and that serves a few important points. The first is that it allows us to manipulate the device in a very easy manner. It also provides good tactile feedback so that you'll be able to get a feeling for where the device is within the patient and the fecal load. And lastly, because of the wide diameter, it prevents the inadvertent loss of the device into the rectal vault. Beyond that, you'll see that there is a lure lock adapter tip, and that communicates with the hollow channel of the device itself. The purpose of that is to be connected to extension tubing, and that's provided with each DisImpactor as well. The extension tubing simply couples to the lure adapter and then allows you to connect a standard syringe through which you'll be able to instill the enema fluid that will eventually exit through these ports. So what you'll notice by just looking at the device is that it answers a lot of the clinical problems that we had posed with traditional digital disimpaction. Essentially, we've overcome the length issue of the finger by having a longer, flexible device. We've overcome the grappling issue where we don't really have traction or means of grabbing by just making a J-turn, because now we have fins, and we're delivering enema fluid much further into the impaction itself, as opposed to a typical enema where putting it into the fecal impaction often simply clogs the port at the very end. So the device itself is very intuitive and really answers the clinical questions that we set out to when we first developed it. So let's talk about the procedure itself in terms of the inclusion and exclusion criteria. What's important to realize is that we need to appropriately select the patients who will be undergoing the procedure. The inclusion criteria are adult patients 18 years of age or older who have a confirmed fecal impaction. That means that both their history and, most importantly, the digital rectal exam confirm the presence of a fecal impaction. We also then have exclusion criteria. The exclusion criteria are relatively common sense. So the first is going to be hemodynamic instability, such that the patient is too unstable to obviously undergo a relatively elective procedure. The next is going to be mental status changes. We need to have a patient that is alert, cooperative, able to give their consent and their feedback during the procedure itself. So mental status changes would preclude continuing with this type of disimpaction. We also want to avoid patients who have severe renal disease or electrolyte issues. And that's because we'll typically be using a sodium phosphate or fleet type enema product, and that can induce electrolyte shifts in some patients. Beyond that, we'd want to avoid patients that are actively anticoagulated or actively bleeding. And we would want to exclude any patients who have intestinal disease, whether that's a neoplastic process, particularly at the anus or rectum, whether it's a bowel obstruction, fissures or fistulae, any conditions that are going to pose a risk, we would want to not proceed with this procedure. And lastly, again, you need to use your clinical judgment. If there's any gastroenterologic or systemic condition that you as the clinician believes poses a risk, then we would not do the procedure in that patient. So let's go ahead and demonstrate some of the features of our kit and talk about how you'll be able to use that on your next fecal impaction patient.